Hi everyone. So I'm Bernina Nesson. So I'm from Aptisen. I'm really happy today to welcome you to our live webinar. And I will present you Dr. Metsavaht, who will present us today his presentation on biokinetic. And so just to do a brief presentation of Dr. Metsavaht. So it's an orthopedic surgeon well known in Brazil. Is based in Rio de Janeiro and is known as a specialist of knee and sports medicine. Is also part of several international scientific and medical society. And he has performed for the past years now like a really innovative and outstanding research that on biokinetics and osteoarthritis and on the joints disorder. And those research was recognized. I mean, this research was recognized last year at the European Orthopedic Congress, the EFORT Congress, where he received the Freeman Award for his work that he will present today. So just before I let Dr. Metsavaht do this presentation, I want to let you know that if you have any question that you want to ask while you are watching the presentation, you can write your question on the right panel. You have a question section on the right panel where you can write your question, and we will moderate the question and ask them to the Dr. Metsavaht when he finishes presentation. So it's now I think that you can start, Doctor, to do your presentation. Thank you very much for being here today.
Thank you very much, Bernina. Thank to you. Thank to Aptisen for the invitation for this presentation. I am very proud of presenting the studies that were awarded last year at EFORT Congress as the Michael Freeman Excellence in Knee Biomechanics. That was unique for Brazil, and we are very proud of it. Thank you very much. So I start sharing my screen for the presentation. Am I sharing already? Yes.
Yes. Yes.
Okay, thank you. So, thank you very much. First of all, I'd like to start saying that Instituto Brasil de Tecnologias da Saúde is a not-for-profit organization for education and research, and all the boards are volunteers. Our mission is to research and create new concepts for preventing injuries and rehabilitating with efficiency. And we are very thankful to all the institutions, corporations, and academics that support in our mission of education and researching as well. One of our missions is also to award young Brazilian surgeons, provide international fellowship for them to study and to research abroad. Until now, we have already financed 17 brilliant orthopedic surgeons to do their research in US. And now we have this partnership with the Midwest Orthopedics at Rush in Chicago, where they spent 1 year researching biomechanics. Thanks to the support of Lehman Foundation, that's why the fellowship program is called Prêmio Jorge Paulo Lehmann, a billionaire and a philanthropist that supports us. Well, we have to remember that an acute dissipation of energy and a split of second are the greatest variables in an equation for a traumatic injury. So it's pretty quick. But whenever we are talking about orthopedic injuries, besides the anatomic alignment of the limbs, we have to think about many other variables that are competing for the loading of those of the joints. And plus, we have time. Different from a traumatic injury, we have years, weeks, months to have a problem, to develop a problem. That's why we have, for example, girls from the same age, same kind of a sport activity with different alignments of lower limbs and still the same symptom. In this case was anterior knee pain. So when our patient comes to our office and says, "Doc, I have osteoarthritis," we have to explain that an orthopedic lesion is not just a matter of luck, of destiny. And the image exams, they show the problems, but they do not explain how you obtain those problems. That's why there is this world trend to create functional analysis to help health treatments and decision making. For instance, nowadays, cardiologists would not rely only on auscultation or just an X-ray of the heart. They need 3D images, but also they need functional analysis of the heart. They need electrocardiogram, angiographies, Doppler, scintillographies, exams that show how the heart is functioning before I start treating. And in orthopedics, we have to think that simply motion analysis or biomechanical studies like strength of range of motion, they do not bring all the information we need. We need 3D dimensional biokinetic tests to allow the musculoskeletal function to be analyzed. So we need algorithms that combine strength, static posture, range of motion, motor behavior, and on the coronal planes and axial and sagittal planes, and also as well as the neighbor joints to explain why one joint has overload. And these musculoskeletal alterations may be exacerbated with movement. For example, in this case, this patient had 9 degrees of orthostatic varus, but when he was walking, his varus went all the way down up to 13.5 degrees. So we have to think that in motion, we may have exacerbation of our alignments. That may influence our treatment decision, making unexpected results. In this case, we could choose change from a uni or prosthesis or osteotomies, or even the grade of correction in the osteotomy. So we have to think more of the dynamic motion. And another point that is interesting that people ask is, exercising and rehabilitating seniors, does it work? Well, there's a lot of evidence in the literature that shows, yes, that middle-aged people can rehabilitate as well as seniors. So both have statistically the same chance of rehabilitating. So yes, it is worth rehabilitating seniors. But the point is that rehabilitating based on vague and subjective criteria minimizes the efficiency and increases treatment dropout. That's the most common problem with senior individuals, is dropout from gym, from Pilates, from physical therapy. Because strengthening senior individuals is not just doing the same thing that we do with the middle-aged people, but with less loads. That's wrong. The point is that we must optimize rehabilitation exercises, strengthening and enhancing motor control only of the muscle groups and segments that really need for locomotion, for standing up, for not falling, you know. And what is very important is that pain control is needed to avoid muscle arthrogenic inhibition. It's impossible to strengthen under pain. It doesn't work. You do not activate all your muscle fibers. So thinking about the presence of pain for rehabilitating the senior individuals, we observed that viscose supplementation is a non-systemic and not harmful option. But there were very contradictory results in the literature. In this paper that was published at the Journal of Bone and Joint Surgery, they were very sure of saying that this systematic review of the evidence, that's a very strong word, about viscose supplementation. But when you look at the data inclusion criteria, they only introduced randomized controlled trials. That's very good. But for knee osteoarthritis, all stages, that means that we may be comparing a brand new car with a flat tire with a very old car with good tires. So it's very complicated. With at least 4 weeks follow-up, that's pretty good. But at least 30 subjects per group. And they were based on pain and function collected through subjective prompts, those questionnaires like visual analog scales, WOMAC, IKDC, Lisham. But whenever we use this kind of analysis, whenever we use this kind of data that are subjective questionnaires, if we put this in the computer, we'll see that we'll need at least 199 patients in each arm of the study to really have the evidence that was written on the title of the study. So studying RCTs with 30 subjects may bring some not so reliable information. So we got motivated to studying viscose supplementation on knee osteoarthritis. And then we saw that numerous systematic reviews and meta-analyses have been published already with contradictory conclusions about the viscose supplementation efficacy. But we saw that in 9 of 10 of these studies, they pointed methodological weaknesses of many of these RCTs. They said that small sample sizes are very common, as low as 11 or 12 subjects. Sample heterogeneity with individuals ranging from a very light osteoarthritis to a very advanced osteoarthritis, and inadequate baselines, inadequate blinding, randomization, allocation, differences in injection protocols, duration of follow-up, lack of intention to treat basis, possible confounding factors, conflict of interest with the industry. So we decided to study the effects of viscose supplementation injection in 3-dimensional kinematic analysis of the osteoarthritic knees in a prospective, double-blind, randomized controlled trial that was in a partnership with UNIFED, the Federal University of São Paulo, the Air Force Hospital of Rio de Janeiro, and IBTS. The IBTS is a private not-for-profit research education institution. The sponsor beforehand accepted publication either if the results were positive or not for their commercial interests. The hospital facilities, healthcare professionals, doctors, nurses, technicians, as well, all patients related to these studies were unpaid volunteers, and all expenses related to medication, laboratory analysis, equipment, rental, transportation, and disposable supplies to perform the study were supported by EPSEN. The objective of the study was to develop a double-blind RCT to analyze the effects of interarticular viscose supplementation in subjects with advanced knee osteoarthritis before and after 12 weeks of infiltration through 3D kinematic analysis of joint range of motion, 3D gait spatiotemporal parameters, and the validated Brazilian Portuguese pain and functional scores, the International Knee Documentation Committee, IKDC, lower extremity functional score, LEFS, and pain visual analog scale, PAS. All patients were at the waiting list for a total knee arthroplasty at the Hospital Força Aérea do Galeão. That is a tertiary health military institution that the average time waiting for surgery for a total knee is 2 years. Our inclusion criteria was all patients over 60 years old, any gender, body mass index, or race, capable of walking without any support for at least 10 meters. And Kellgren-Lawrence grades 3 and 4, only advanced cases. The exclusion criteria was similar to most studies we see in literature, like neurological function impairment, and we had approval of the ethics committee. So, to get a power of 80% with a level of significance of 5%, we needed 20 subjects in each arm of the study. We were not using subjective scores, but very objective 3D motion analysis scores. So we needed 20 subjects in each arm of the study. And we had 156 patients in the waiting list, and 114 were not included, most of them because they live very far away from Rio de Janeiro. This is a military institution, so they were from other towns and they could not be coming back and forth. So we randomized for 42 patients at the intention to treat basis. We allocated 21 in each arm of the study. We lost follow-up of 2 patients in each arm. One had a stroke and the other one abandoned. And in placebo group, one had a chikungunya fever and the other one abandoned. So our final analysis was of 42 subjects, and the data was included as last observation carried forward. This is the Air Force hospital in Rio de Janeiro, close to our international airport. This is the day hospital where all the procedures were performed. All the patients were admitted and released at the same day. All the patients were transported in stretchers to the procedure room. And this is the intervention room setting. No nurses. All the nurses that bring in the patient, they would leave and leave the doctors alone. And we had an ultrasound. All the patients were blinded, boxes with active and placebo. The viscous supplementation was performed with Sinolise VA, hyaluronic acid 80 milligrams, and sorbitol 160. We were careful even to have the same kind of sounds produced on opening the box of an active medication like this one, because the Sinolise comes in a locked box and produces a sound when we open. So we did the same procedure to the placebo. So we created these fake boxes for the placebo procedures, so the patient would hear the same sound. And all interventions were performed within 7 weeks. We did local skin anesthesia with 2 ml of lidocaine, and we allocated the patients immediately before intervention. The patients were already ready and with anesthetics, and then the sealed envelope was opened, and then we would inject either 4 ml of saline solution or the hyaluronic acid. The infiltrations were through the superolateral portal of the knee, guided by ultrasound in every patient. All supplies were deposited in boxes and closed before the surgical field was removed. All the envelopes returned to the randomization folder. All patients were oriented to maintain their routines with non-pharmacological treatments and physical therapy like crutches or whatever. Paracetamol and ibuprofen as rescue for pain were allowed, but no any compound with cortisone, either cream, capsules, or injections were allowed. 2 blind and orthopedic surgeons of our team were designated for a follow-up if any intercurrence or emergency would happen. They were with their special unique cell phone that was 24 hours, 7 days a week. They were accessible for the patients. And one blind secretary was designated for the appointments, for the procedures, and the biomechanical analysis. So in this slide, you can see that the same process was performed for every patient. We had camera in the room filming every patient, every procedure. And as you can see, every patient was randomized immediately before injection, and then as chosen as the placebo or the active substance, then our colleague would perform the injection on the knee, guided by ultrasound. And it's very, very interesting to see that it's very easy to see when the viscose supplementation gets inside the joint. It gets very clear. We can see in this image right now, it like some stars opening in the joint, you know, getting into the synovial fluid. It's very, very interesting. So all the analyses were performed at baseline and 12 weeks after the injections. The whole study took 5 months, and now involved personnel for data collection, processing, interpretation, and statistical analysis were completely blind. So all the questionnaires were performed in person, not by telephone. The patients would fill the forms by themselves. The 3D spatial temporal parameters were collected, as well range of motion, the range of motion and strength was collected, and 3D motion analysis of all patients. So the results we had were that on baseline, there was no statistical differences between the groups, either for pain, AKDC, and LEFs. So the groups were very homogeneous. But after intervention, what we observed was that both groups had improvement in pain after 12 weeks. Both groups had improvement of quality of LEFs, and both groups had improvement of their International Knee Documentation Committee analysis. And there were no different changes, no statistical changes between those groups. So the groups were very similar for those subjective questionnaires. Also, in spatial temporal parameters, after 12 weeks, we observed that both groups decreased initial double leg stance time. Both groups increased single leg stance time. Both groups increased step length, and both groups increased step stride. So no differences. On 3D active range of motion, we observed that the viscose supplementation group increased sagittal plane active maximum flexion and extension of the knee. So with the blue arrow, we can see that the knee keeps all the time during load phase, almost with no flexion. And in the red arrow is the same patient 12 weeks later. You see that he can do more flexion and more extension of the knee. And even the posture of the trunk and the pelvis is better. So the increased flexion and maximum flexion and extension of the knee. And what was really curious that we didn't expect, that after 12 weeks, we observed that a decreased actual plane of motion. So in the placebo group, less rotation. So it was like a locked knee in internal rotation. We cannot conclude anything about that, but it seems that they were locking the knee to minimize pain. So the results of this randomized trial demonstrated that we have similar improvement of pain and quality of life and subjective parameters after infiltration of viscous supplementation and placebo, but we should be regarding that injections of saline placebos, they have a superior placebo effect than oral pills. That was published by our partners in Chicago from the Midwest Orthopedics. And we have to regard that subjective scores, questionnaires, spatial temporal parameters may not be the adequate tool to analyze changes in pain and function in the small sample sizes. It's not that questionnaires are not reliable, they are very reliable, but we need larger sample size. They are not adequate for small sample sizes. So it's not that they are not adequate. Simply, when we want to measure something, we need to use the right tool to measure. So a ruler is a very reliable measure, but not for fever. And the results of this study demonstrated that viscous supplementation improved active range of motion of individuals with knee osteoarthritis. And the 3D functional range of motion is a very sensitive tool to identify even small changes on motion of the human being. And we have numerous studies showing that increasing active knee flexion and extension are very important. Thomas Andriaki from Stanford was one of the most important researchers on this matter. And in his studies, we see that increasing the quadriceps function is very important for motion, for gait. It decreases loads in the knee joint, improves the quality of gait, and possibly increases lifetime of knee joints. So our conclusion is that comparing infiltrations of viscous supplementation and a placebo, pain and subjective functional outcome scores did not show any statistical difference between groups. But the viscous supplementation group showed increased active maximum and flexion angles in the sagittal plane of the gait, statistically relevant. And the placebo group showed a decreased total axial plane rotation of the knee after 12 weeks. And for these studies, we were awarded with the Michael Freeman Award of Excellence in Knee Biomechanics, which we are very proud of it, and very proud to share with the Brazilian scientific community. And for those that know that Rio de Janeiro is a beautiful place, I invite you all to come to Rio de Janeiro. You won't regret the beauty of this place, but also remember you that we have marvelous centers of excellence in research for orthopedic surgery. We have the Hospital of the Air Force. We have the National Institute of Orthopedics and Traumatology, the Federal University of Rio de Janeiro, and the State University of Rio de Janeiro. They all produce a lot of marvelous science to the world. And finally, I'd like to thank for your attention and remember you that our vision is to identify the causes of orthopedic problems to allow preventing and rehabilitating with efficiency. Thank you very much for your attention.
Thank you, Dr. Metsavaht, for the presentation, and it was a really good high quality presentation. Thank you very much. I think that the content is it's quite interesting, and it's another reason to see how you can quantify and determine if a treatment is efficient for the patients, but as you demonstrated, it's difficult to find the right tool to define the efficiency of a treatment. But to your opinion, do you think that if you had selected patients with maybe a grade between 2 and 3, you would have been it would have been possible to see a better difference between the viscose supplement and the placebo regarding the pain measurement?
Yes, Bernina, what we do in our practice is our good sense as physicians. We went to university, to residency, to post-graduation. We study a lot our whole lives. What? To have a good sense, to have a good decision. And we need science to show some evidence under our decision. But we need to generalize what the science shows us. So we found evidence that viscose supplementation works very well for advanced knee osteoarthritis. And we can infer that that works for lower grades. The problem about studying lower grades is that you have a mixture of problems. You see, these patients, even if they don't tell you, they may change their routines of exercising, loading during the day, you know, so it brings a lot of noise to your research. So we research in these very advanced cases that we knew that they wouldn't do anything, they wouldn't change their routines, you know, and they were already in the line for surgery. So we can infer well, I have 30 years practice, you know, so yes, I allow myself to infer that if they had improvement, these advanced cases have improvement in pain, surely the less advanced cases would have too.
Okay. Okay, good. Just to remind to the attendees that if they have any question, they can write the question down or raise their hand, and I will give them they can unmute their microphone. But
And
do you recommend? So I have a question for you. The question is: do you recommend this viscose supplementation treatment to any degree of arthrosis or just the highest one? So I think that you answered the question.
Yeah, I can now. This is a direct question. You know, I can say my personal opinion, of course. Yeah. You know, yes, I recommend. I don't recommend to very early stages because I really think that early stages. The most important thing for you is to allow this patient to rehabilitate. If he's overloading the knee joint, first you have to unload that joint. So try to find the muscle imbalances and try to rehabilitate that. And if it doesn't work, then I use viscose supplementation to minimize pain and to improve rehabilitation, as we said in the presentation. It's very difficult to rehabilitate or to strengthen a patient that has pain. You know, so it's our duty as physicians, and physical therapists do that as well with their means, physical therapy. We have to reduce pain to allow patients for strengthening and stretching and having a better muscular control.
Okay, thank you. Let's switch to the other questions. So the other one will be if the movement improved, it means also that the pain is reduced, because when the patient with knee joints suffer from pain, they move less. So, but
exactly.
with your experiment and with your trial, you show that you have an improvement in the motions. So it may have, so it's also, it resonates with the improvement of the pain also. So the difference, I mean, because whenever we discuss about the results, people say, yeah, but compared to the placebo, we don't see any differences. But the thing to understand is that the real result is that the tool that was used to measure the pain is not accurate. And can you elaborate on this point?
Yes, that's a very good question, very pertinent. The thing is about these studies exactly that, is that you can use these subjective scores of pain, to analyze, but then you need a huge data. You need a lot of patients because this data is very subjective. So it depends if the person is a good mood or in a bad mood, if had a good experience, bad experience. So many things influence the pain perception. While 3D motion analysis, not. So it doesn't matter if the person is in a good mood or not a bad mood. So we can measure function in very, very low degrees or millimeters of change. It's very, very high quality measurement. So we need very smaller sample size. Bigger sample sizes are good, but it's very difficult. It's very difficult for you to get to any research institute in the world to have 400 patients to randomize 200 in each group, and that has to be the same level of the same stage of osteoarthritis, and they all have to be studied in a very quick time. Some studies do that, but they take about 2, 3, 4 years to do that. And in 2, 3, 4 years, you changed a lot of things. The patient changes. The patient gets older. The doctor changes. The residents change. The people who make the injections change. So we have to minimize the most all these confusions in research. That was our focus on this study. So yes, all patients in 12 weeks, they have this perception of having got better. But the thing that we found is that the placebo group locked the knee in internal rotation of the knee. So I would informally explain that that's like when you step into something that hurts your foot, and then you start walking with supinated foot, to avoid stepping on what is hurt, So you don't feel the pain. So, but you're changing your motion to avoid pain, So that's a very important sign, and it is, as the person who made this question, the moment there are many studies showing that to avoid pain on the knee, the patient either locks it in full extension or it locks it in some grade of flexion. So this is the way we usually do to avoid pain on the knee. We lock the knee, So it minimizes pain. It's very effective for minimizing pain. But on the other hand, it increases a lot the loading into the joint. When you lock the knee, when you don't have your knee doing the right job, all the flexion and extension, you're overloading some small areas of the knee. So you avoid pain, but your osteoarthritis may get worse even faster.
Okay, thank you. I have a more practical question for you. Is there indication to use Synolys to meniscus lesion?
Well, it depends. We had a meeting 2 nights ago of the Brazilian Knee Society of Campinas here, and we were talking exactly about this matter. It depends. I wouldn't. It wouldn't be indicated in acute lesions of the meniscus, but in degenerative lesions, it would be well recommended, because the conclusion that we got in this meeting was that nowadays you have to think many times before operating degenerative lesion of the knee, of the meniscus. You should try to rehabilitate before surgery, because actually these degenerative lesions of the meniscus are the pre-osteoarthritis situation, you know. So you should try to avoid surgery in elderly people with degenerative lesions. And in this case, all the conservative treatments are welcome. And Synolese would be one of them, of course.
Okay. Okay. So I think that for the questions, that's all we have. I would like once again to thank you very much.
There's one more question here. There's one question here. There's someone asking if I use cortisone to
I don't
together. No, in this study, it was really interesting because we know that many physicians, they use cortisone along with viscose supplementation, and we did not use cortisone in any case. We just used the viscose supplementation, okay? And there's another one, okay, and someone is asking if I drained the effusion. And then, no, we didn't drain. These are a very good question because they're very common things to do in our clinical practice. When we see that knee full of synovial fluid, we drain. Some physicians put some cortisone and then viscose supplementation. In this study, we did not drain any patients. It seems incredible that, yes, but we had these marvelous results even without draining any effusion.
How do you explain this this phenomenon?
We don't know. We are doing science. That was a question of the study, you know. But the problem, Bernine, was that when the first patient came in, there was this big effusion, and we had to decide drain or not. And we decided not to drain, because if we drained one knee and did not drain another knee, we would be bringing bias to the study. Yeah. We were analyzing knee osteoarthritis. It doesn't matter if the knee had synovial fluid or not, you know. So we could not bring another confounding factor to the study. So we decided just to use Synolese in all cases, either with effusion and not effusion, and the results were good as well. So it may be that we physicians, when we have this patient with a knee effusion and pain, we as physicians, it's natural for us. We want to do the best for them, you know. We want them we want to solve the problem of pain. So sometimes we may exacerbate even our actions. Maybe we are draining and injecting cortisone with no reason, you know. So maybe it's not necessary. So maybe it should be interesting to have another study in future comparing draining without and not draining, you know, two different groups, both with viscose supplementation, and one draining and another draining, and another with draining, and one with cortisone or not. There are some studies in the literature showing comparing viscose supplementation versus cortisone injection, and they're pretty similar results, you know. But again, small sample size studies, analyzing subjective questionnaires. Subjective questionnaires, you need 200 patients in each arm to study. You know, you won't get any evidence. It's not that this study is not good. Please don't misunderstand me. Every study that shows results is good. We should be careful only to use the word evidence. If we want to have evidence using subjective questionnaires, we need larger sample sizes. If we want evidences with a smaller sample size, we need to use these tools, 3D motion analysis, biomechanical tools that measure very small changes to have some evidence. That's the problem. That's the only point. It's choosing the right tools to measure results.
Okay. Okay. And I think that you mentioned also that the combination of corticosteroid and HA intra-articular injection, and to my I mean, from a scientific point of view and in terms of technology for Synolis, we don't need to combine both. Can you like share your experience about this practice that physicians do, because they tend to have a fast action of the corticosteroid to reduce the pain and use the HA for the long-term effects. But we tend to say that, I mean, we explain and we have some clinical, and we have clinical data that with Synolis you don't need to combine both for two reasons. Is that the first one is that you can degrade the gel by combining corticosteroid to the HA. That was proven in vitro. And the other thing is that with Synolis you have for the first couple of weeks, I mean, few days after injection, you have an effect. So can you share your experience about that, and like how by using Synolis maybe you have a reduction of a co-injection of corticosteroid and HA?
Okay, this is my personal opinion.
Yes.
Okay. Honestly, I do not use cortisone in any case. I personally have 30 years of practice. Simply, I don't like injecting cortisone in joints or tendons. You know, it's a tool. I agree with the colleagues that do it. You know, but personally, I don't do it. I don't like I don't like what's seen in literature about the harmful effects of cortisone in joints and tendons. So personally, I do not use. So what I do normally in my office, I didn't do in this, but normally I drain the knee if it's too large, and because the pressure on the knee is not for the Synolis to work. It's just too much pressure on the knee. It's painful, so we want to relieve the patient. So I drain excess of synovial fluid and use Synolis itself without any cortisone. And what I do sometimes a week before, I use mesotherapy. That is an European technique of using local NSAIDs, just to help a little bit, take a little bit of inflammation. But I never use cortisone with Synolis.
Okay, I have a question more for the sport related. Can we use the Synolis with athletes performing competitions?
Yes, I don't see a reason not to. It's a medical decision.
Yes.
There are several studies going on studying the effects of Synolis and viscose supplementation as a whole in joints and tendons of athletes that are subject to big efforts and overload of the joints. It's something that it's sensate, it's smart, it's wise, because athletes are under overload the whole time. So it's good sense to research that. So, and as viscose supplementation for many years have been used without side effects, otherwise than bad procedures. If the person is not trained to do injections of the knee, they should not do it. Those are the only complications we have. But the drug itself doesn't bring any harmful effects to the joint, as cortisone has done. Have a lot of studies showing that, and no study until today have shown side effects in the joint of hyaluronic acid. So why not? Why not help? But that's a medical decision. It
Yes.
still needs some evidence for research, you know.
Yeah.
But I don't see any reason not to make a medical decision and use it.
What is your opinion between viscose supplementation and PRP?
Well, PRP is forbidden in Brazil, has been forbidden for a few years. Only for research they are allowed until now. And another personal opinion, okay, I don't use PRP. I don't use PRP because actually we have even partnership with a few centers that study that a lot of PRP, and it's being very much studied in many places in the world, but still I haven't read one paper showing evidences of some benefits of PRP in osteoarthritis with the same problem that we see with viscose supplementation. Small sample sizes or using subjective measures. So it is not that I don't think we should. I think it's like cortisone. It's a choice of the physician, but it's not my choice. My good sense tells me that I should, in this osteoarthritic knees, I should simply provide pain relief, keep that joint a little bit more smoother to allow a good rehabilitation. Actually, I do not treat my patients only with Synalise. I use Synalise, and when the pain is less, then they start rehabilitating, you know, and then rehabilitating is more effective. So that's the point. It's not just giving medication to the patient. You have to rehabilitate. You have to provide them functionality again, you know.
Okay. So I think that this time we went through all the questions, unless someone wants to write down another last question that can be answered by Dr. Metsavaht. I think we have one. Did you face I don't understand the question. Did you face the worst pain after? Do you think that some patient may have pain after injection of a shot of Synalise? Have you ever experienced patients with pain after a Synalise injection?
No, I haven't. I can give two opinions about that, a scientific and a personal opinion, because in our study, we had that blinded secretary that she called every patient that was injected on the next day and after a few days, and they were asked in every return for a biokinetic analysis if they had pain after the injection. And neither of them had worsening of the symptoms. No one.
Okay.
Oh yes, we have a scientific opinion about that. Okay. Only a few complain of some pain at the injection place. Well, that's normal. We never injection that we take in the body, you know. But no increasing of the symptoms, neither. And in my private practice as well, I have never had. I have very little complaints of patient not satisfied with the result. It's very little. But most patients in the first week or the first 2 weeks, they return saying that they are better.
Back to normal. Yeah, better. It's
pretty quick effect. I normally tell them to return in 2 weeks, you know, and to be sure. And in 2 weeks, normally they say that they are thanked. They are thanked for the procedure.
Okay. Okay. So I think that this time maybe someone else will ask another last question. But I really want to thank you, Dr. Metsavaht, for the presentation and sharing your experience. It's always a pleasure to listen to you and to discuss with you. I think that it was the same for everyone. But if you have more questions, you can write down those questions to the marketing email address, and we will ask it. We will write it down to you, and you can answer to this question. If anyone has another question that will pop up after the presentation, or if they want to ask something, they can still ask any question that they want. Thank you again.
Also, if anyone would like to email me, please feel comfortable to email me. My email is pretty easy. It's Leonardo at Brasil Saúde for Brazilians, Brasil Saúde altogether, .org.br. And also my Instagram is at Leo Metsavaht. So it's pretty easy to find me. Google Leonardo Metsavaht, you'll find some way to email me. It's going to be a pleasure. Okay.
Thank you once again. Have a good evening. No, have a good day.
Yes, Bernina, here in Brazil is noon now. It's actually almost 1 p.m. Time for lunch.
Okay, so enjoy your lunch.
Yes. Thank you very much for the invitation, and thank you for APSEN for supporting our research. We are very proud of this partnership. Thank you very much.
You're welcome. Talk to you. Bye.
Bye-bye.